Hello, everyone. This is Dr. Mickey recording a lecture on Chapter 44. Just a reminder that half of this or part of this chapter was covered in Patho Pharm 1 last spring semester, NUR338. We covered the pathophysiology and drugs medications for the pituitary gland, like hypopituitarism, hyperpituitarism, diabetes insipidus, and the SIADH syndrome of inappropriate ADH hormone. All of that content was covered in Patho Pharm 1, so I recommend that you go to that content and review that. And for this semester, we'll be focusing on the remaining content from that chapter on the remaining content for the endocrine system, which will be divided into two sessions. Today's and tomorrow's or Thursday's session if you're on section 2. So Monday, we will go over the adrenal glands, pathophysiology, and the medications drugs for the Cushing syndrome, Edison's disease, pheochromocytoma for the adrenal glands. And then the other session, like Tuesday or Thursday, if you belong to section 1 or section 2, we will cover the thyroid and parathyroid disorders, medications, and pathophysiology. So this recorded lecture will be focusing on the adrenal gland disorders, Cushing syndrome, hypercortisolism, Edison's disease, pheochromocytoma, and we will focus on the pathophysiology, medications, and nursing role in the pharmacologic management of adrenal disorders. So this is the review or the learning outcomes objective from the part 1, which was covered in Patho Pharm 1, and then for Patho Pharm 2. For today, that will be, these are the objectives or learning outcomes from this section, with a focus on the adrenal disorders like Cushing syndrome, hypercortisolism, Edison's disease, pheochromocytoma. Again, we'll focus on the pathophysiology, medications, nursing role in the management of these disorders, and any implications pertains to the side effects and mechanisms of action and adverse reactions for these drugs and medications. So expect that also that there will be a pre and post quiz tomorrow. Monday and Tuesday or Thursday, we'll have the pre and post. The same quiz will be administered like at the outset before the lecture and then towards the end of the lecture, and see how, what the effectiveness of the session. So that will be done online, ATI, about like 10 very short quiz, 10 questions, less or more. So the EMP, just very quick overview of the anatomy and physiology of the endocrine system, in which that we recall that the endocrine system is basically the pathophysiology, and the disorders is better be explained in terms of the dichotomy. Like if you master one side, or like hypo secretion, then you kind of predict the other side, which is the hypersecretion. So like hypopituitarism, you'll be able to, once you master that kind of like manifestations, pathophysiology, medications, you can pretty much, I would say, to a high extent, you can predict the hyperpituitarism, for example. Here for adrenal gland, if you let's say mastered and competently understand and able to like recall and explain and master the content for Cushing syndrome, given this dichotomy, structure of the endocrine system, you'll be able to predict the pathophysiology, manifestations, medications for the Edison's disease, which is exact opposite to the Cushing syndrome. So again, this is one of the concepts, like, I would like students to understand that, once you master one side, you'll be able to predict and understand the other side, because it's basically It's either there is a decreased secretion of hormones or increased secretion of hormones. So another overview is that, the master gland for the endocrine system that controls all the other glands is the hypothalamus. So we have an axis kind of control the endocrine system functions, is based on the three levels. The highest level, which is the hypothalamus, like a master gland, and the gland that controls the rest of the glands. So that would be like level 3, or the highest level. You can call it just the highest level. The second level, in which the hypothalamus will control the P gland, the pituitary gland. And the third level would be all these glands that are responsible for producing these hormones. So if we think of hypothalamus and then the P gland, this is the pituitary gland, anterior lobe and posterior lobe. And then the P gland will control the rest of these glands. So this is called the hypothalamus pituitary axis, or HPT axis, H, which is hypothalamus, P, pituitary, and then T, the target gland. The target gland can be thyroid gland, or the gonads, or the ovaries, or the mammary glands, or let's say the pancreas, which will produce like insulin, and adrenal gland to produce the adrenal cortical, which will produce the cortisol. So parathyroid, which will produce the parathyroid hormone, PTH hormone. So all of these, see, these are adrenal gland, cortisol again. So again, the hypothalamus will control. It controls so it secretes some chemical components or secretions or hormones or factors. It's usually called factors, will be released to stimulate the P gland, pituitary gland, either anterior or posterior lobe, in which, in response to that, the anterior lobe or posterior lobe will produce additional like hormones to stimulate these target glands. So an example of this one would be the thyroid releasing, like, for example, factor or stimulating factor from the hypothalamus to the P gland, and then the P gland, the pituitary gland, the anterior lobe, will produce or secrete the thyroid stimulating factor, TSH. So this TSH released from the anterior lobe of the P gland, pituitary gland, to stimulate the thyroid to produce thyroid hormones like T3 and T4, triiodothyronine and T3, and thyroxine T4. So these will be produced from these hormones measured in the blood from the thyroid, has been stimulated to be produced, secreted by this TSH hormone from the anterior lobe. The posterior lobe, so anterior lobe stimulates too many hormones, TSH, ACTH, adrenocorticotropic hormone, to stimulate the thyroid, the adrenal gland, which are on the top of the kidneys, to produce the cortisol and other hormones. Another example is the FSH hormone, which is the hormone usually stored in the P gland, but will be released for ovulation. Luteinizing hormone, same thing, and then prolactin to stimulate during the lactation period. For example, after having a baby, then that's for good for breast feeding. Another example would be also the growth hormone produced to stimulate the development of the bones. Other hormones. So the posterior lobe produces. So anterior lobe, too many hormones. The posterior lobe of the P gland produces only just two hormones. One, oxytocin, and we know its function required for the contraction of the uterine contraction during the labor and delivery. And then we have the another hormone, which is the ADH hormone, vasopressin, or antidiuretic hormone. So so I have only two hormones from the posterior lobe of the P gland, and the rest of the hormones will be released from the anterior lobe of the P gland. So again, this is we also explained last semester about, when we went over the feedback mechanism, and most of the mechanisms that govern the endocrine system are of a negative feedback type, but very few of positive. For example, like the positive, which is the prolactin secretion, will lead to more like, kind of milk production. But most of the feedback mechanisms are of the negative type. An example of this one would be like, if there is an increased secretion of T3 or T4, then the TSH will decline in terms of production, because there is a message will be sent through the hypothalamus to the P gland to reduce its production of TSH hormone, because they have sensed there are too many thyroid hormone in the blood. So this is the type of negative feedback mechanism. Another feedback mechanism, negative feedback mechanism, would be the hypocalcemia. So in which that, when there is a low calcium level in the blood, hypocalcemia, then the message will be sent to the parathyroid gland, which are, these are the four tiny glands in the back of the thyroid. They are posteriorly located. These parathyroid glands will produce what is called the PTH hormone, parathyroid hormone. And this hormone has been produced from the parathyroid glands, the four tiny small glands. The hypocalcemia stimulate the production of this with the negative feedback mechanism from the hypothalamus, which has sensed this hypocalcemia in the blood. It will send the message to the P gland, pituitary gland, to stimulate the parathyroid glands to produce the PTH hormone. So when the parathyroid glands produce the PTH hormone, the parathyroid hormone has three significant mechanisms in which it will bring this hypocalcemia and boost this calcium level by doing three things, and we'll cover this under the thyroid parathyroid section. We'll go in more details about the pathophysiology of that. So this is just an example of the negative and positive feedback mechanisms. So for this lecture, we're going to focus on the adrenal glands and the three main disorders that under this gland or disorder of the gland may lead to Cushing syndrome, Addison's disease, or pheochromocytoma. So Cushing syndrome, which is pretty much, I would say, very similar to patients with hypercortisolism. So when the cortisol level increases, then that will cause what is called the Cushing syndrome, or the I don't want to differentiate between the Cushing syndrome and Cushing disease later on, but the Cushing syndrome or Cushing disease, it's the that's an elevated cortisol level, or a steroid cortisol level, and then the Addison's disease, the low cortisol level, and pheochromocytoma, that's whole different disorder, but it affects the adrenal gland. So these are the three main disorders that we're going to cover in this section, or in this part of the endocrine system. So the adrenal glands, as you know, we have two adrenal glands, one on the top of each of kidney, and these glands, they produce hormones. The main hormone produced by the adrenal gland is the cortisol. And this explains the three levels of the feedback mechanism, how the HPT, or in other words, the H, which is hypothalamus, P, which is the pituitary gland, and then the T, which is the target organ. Here it's or gland. The target gland here is the adrenal gland, or adrenal cortex. So adrenal gland, especially the cortex, which is especially responsible for the production of the cortisol, not the medulla. The cortex is responsible for the production of the glucocorticoids, which is the cortisol. So you can apply the same level of the three levels, like hypo, HPT, to any endocrine gland. So this is an example of the HPT hierarchy. Hypothalamus controls the P gland controls the rest of the endocrine glands to produce certain hormones. In this case, we have hypothalamus controlling the anterior loop of the pituitary gland, and then this P gland produces the ACTH hormone, adrenocorticotropic hormone, which will stimulate the adrenal cortex of the adrenal gland to produce few hormones. The main one is the glucocorticoid, which is the cortisol. And also we can include here another hormone, which is the aldosterone, which is the mineralocorticoid, which is responsible for the sodium and electrolyte, fluid electrolyte balance. We'll talk about that in a few minutes. So the four major or main disorders and under this adrenal gland disorders we know, as we have mentioned earlier, the Cushing syndrome or disease, and would differentiate between the syndrome and disease, and then the Edison's disease, hyperaldosteronism, and the pheochromocytoma. So the adrenal cortex secretes glucocorticoid, which mobilize the body for long-term stress, fight, flight response, and the it also influences the metabolism of the carbohydrates, the lipids, the proteins. That glucocorticoids are responsible for that metabolism. The mineralocorticoids, they're responsible for the fluid or water electrolyte balance. And then the gonadocorticoids, they are mostly male sex hormones like the androgens. The control of the glucocorticoids, the hypothalamus, so the control of the glucocorticoids, which is the most important hormone in this for this chapter, which is the cortisol, or the glucocorticoid, which is cortisol. Now, the hypothalamus releases the CRF, which is the corticotropin releasing factor. So again, we said that the hypothalamus controls the P gland, and P gland controls the adrenal gland. So how is the hypothalamus would control the pituitary gland? The hypothalamus would release what is called the CRF, which is the corticotropin releasing hormone, that to stimulate the pituitary gland. So it will stimulate the anterior lobe of the P gland, pituitary gland, to produce the ACTH hormone, adrenocorticotropic hormone. And then that P gland anterior lobe, when it, with that ACTH hormone, it would to stimulate the adrenal gland to produce the glucocorticoids. So that's the three levels of the control or how the endocrine system works at three levels: hypothalamus, P, pituitary gland, and then the T, which is the target organ. In this case, it's the adrenal gland, HPT. So when for example, when the cortisol level rises, increases in the blood, then there will be a negative feedback mechanism that will shut off the release of the glucocorticoid from the adrenal gland. And we'll talk about this in terms of the reason for tapering off the steroid medication or therapy should be tapered off and not to abruptly discontinued, and the mechanism for that. So these are the hormones are produced from both sections or areas of the adrenal gland, either from the cortex, in which the cortex will produce the cortisol, glucocorticoid, and the mineralocorticoid, which is the aldosterone. And just to remind, as a reminder that, or review that the aldosterone hormone produced from the adrenal cortex are responsible for the fluid electrolyte balance. So patients with high aldosterone level, they will have a fluid sodium retention because the hormone, the aldosterone, is responsible for the sodium retention and potassium excretion. So patients with high aldosterone, so this is hyperaldosteronism, they will have fluid retention, sodium, like sodium retention, like hypernatremia, and then potassium loss, which is hypokalemia, and androgens as well. However, the adrenal medulla, the inner tissue of the gland, produces the dopamine, norepi, and epi, and obviously, we can say that the absence of the adrenal medulla, it doesn't really upset the maintenance of the homeostasis, and that's because we have other organs and tissues in the body other than the adrenal gland that is responsible or can produce these hormones. But the only hormone that's usually produced from the adrenal gland are these two main hormones are cortisol and aldosterone. So now the cortisol, this is the function of the cortisol. Carbohydrate, protein and fat metabolism, the fight-flight response to stress, the emotional stability, the immune function, and this explains, the pathophysiology or the rationale for the immunosuppression, and for those patients who take the steroids. So steroids or steroid therapy, it's immunosuppressant, and we'll explain later on the mechanism in which that the steroid will lead to the immunosuppression. Aldosterone, as we said, that it maintains the extracellular fluid volume, especially with the not just the fluid but also the electrolytes, mainly sodium and potassium, because the aldosterone promotes the sodium and water retention. So patients will have fluid retention, water excess, weight gain, and then they will lose the potassium in the urine, so they will end up with hypokalemia. So the Cushing syndrome. So let's focus on the Cushing syndrome first, as the heightened or high release or secretion of or increased secretion of the cortisol hormone. So the cortisol, when there is an excessive secretion of glucocorticoid, particularly will be the glucocorticoid, which is a steroid, in this case, cortisol. There is a high cortisol that will lead to reducing the lymphocyte activity and then the immune suppression. So in other words, that this reduction in the lymphocyte activity, it doesn't really affect the number of the lymphocytes or the neutrophils. So the neutrophil count is high, but there is low cytokine, and this cytokines makes them inactive. So we have a good number of neutrophils, good number of lymphocytes, but the loss of this cytokine make them inactive. So we have inactive lymphocytes, inactive neutrophils. So that's why the high cortisol will lead to the immunosuppression. And we have three different types of Cushing. Either it's a disease, pituitary, adrenal, or what is called the Cushing syndrome. And the Cushing syndrome is the most common among the three types. So the etiology and pathophysiology of the Cushing syndrome, why patients develop this, or that, which leads to increased cortisol level or glucocorticoid level. So it's either endogenous or exogenous. The endogenous, that's pituitary like neoplasm, in which there will be an increased secretion of the adrenocorticotropic hormone from the P gland, and that would be like an 85, accounts for about 85% of all the cases, which is the most common cause here. Other etiologies like adrenal hyperplasia or adrenocortical neoplasm or cancer affecting the lungs, GI, or pancreas, and then metastasize to the adrenal gland. That could be the case. However, the exogenous cause in which that the iatrogenic means is something that has been caused or inflicted to the patient because of the medical intervention. So the iatrogenic administration of exogenous corticosteroids, patients who receive the cortisone or steroids for long-term, like patients with asthma, for example, patients with exacerbation of asthma or COPD or autoimmune disease or organ transplant, then post-organ transplant, patients should be on immunosuppressant agents long-term, lifelong, cancer chemotherapy, allergies, and chronic fibroses. All of these requires that patient should be on the long-term corticosteroid or steroid. So Cushing syndrome, clinical manifestations, the previous figure explained or viewed all these manifestations, like, for example, the weight gain, which is most common due to the change in the fat distribution, trunk, that patient would have the truncal obesity, facial, like the moon face, rounded moon face, and then cervical or cervical area, and this would look like the patient has like a buffalo hump. The sodium water retention, there will be fluid volume excess. Patients will have hypernatremia, hypertension, elevated blood pressure from the sodium and fluid retention. The hyperglycemia, patient would have a glucose intolerance, in which that this one is or this manifestation is associated with the cortisol-induced insulin resistance, because the because of this corticosteroid or cortisol-induced insulin resistance, patient will have a glucose intolerance and hyperglycemia. And you have noticed or seen, patients with, at the acute care setting in the hospitals, when they receive or, when they take the steroids, especially the IV steroid, they will have a hyperglycemia, and then they will be put on the insulin glucose sliding scale coverage, insulin sliding scale coverage for those or patients who receive steroids, because we anticipate that they will have hyperglycemia. The increased gluconeogenesis by the liver, making the glucose from the protein, because the liver will store the protein, and then the protein will be a source of the to make the glucose or be converted to glucose. So glucose become like a source of energy from the protein being stored in the liver. So that's another reason for the hyperglycemia. Another reason for hyperglycemia, which is that there is a muscle mass loss, which reduces glucose uptake. So with the loss of the muscle mass, then there is the decreased or reduction in the glucose uptake, and that would lead to the hyperglycemia. And we said there is an hypokalemia, but it's unexplained, but part of that could be related to that. The Cushing syndrome, there is an increased production of the aldosterone, in which we said that the aldosterone will lead to the hypernatremia, fluid volume excess, and hypokalemia. So that could be partially explained by the hyperaldosteronism, high aldosterone production. Now, the protein muscle wasting. So as we said that, as have seen from that figure that, how the patients would have a lot, the protruded abdomen and the trunk, back the fat depositions in the trunk area, and with the thin extremities. So there is a catabolic effect of cortisol, or this kind of wasting, muscle wasting, or protein muscle wasting, that's due to that catabolism from the, affected by the cortisol level, high cortisol, which leads to the weakness, and that's due to also increase in the breakdown of the tissue protein and increase in urine nitrogen excretion. Now, the musculoskeletal changes, that's due to the nitrogen depletion and the mineral loss. So there is a loss of the bone density. The protein loss in the bone will lead to the fractures because of the osteoporosis. Bone and back pain, that will put the patient at risk for falls. The muscle mass also decreases or reduced. That will be most affected will be the arms and the legs. So upper and lower extremities in terms of reduction in muscle mass or muscle wasting. The loss of the collagen, there will be an increased blood vessels, which is very fragile, thin, tiny blood vessels, which will lead to the bruises and ecchymotic areas, purple stria on the abdomen, like thin threads, red colored, on the buttocks, the breast as well. So these are from the loss of the collagen. The wound healing will be delayed, and we know this is for patients with Cushing syndrome or patients on steroid therapy. They're at risk for that as a side effect as well. So that's due to the decreased immune function. We have mentioned mentioned part of that earlier about the decreased function and decreased inflammatory response. So patients, they are at a greater risk for infection, and they may not have the expected inflammatory manifestations like fever, purulent exudate, redness. They may not be presented or exhibit these like inflammatory manifestations. So that they may, they could lack these manifestations because of that immunosuppression or the decreased inflammatory response. The GI symptoms, the ulceration, so this is another side effect. It's like a manifestation for Cushing syndrome because of the increased cortisol, and same thing, it's a side effect, for patients on steroids. GI ulcerations, and this will be from results from the increased hydrochloric acid secretion and decreased production of protective gastric mucus. So it's due to two things: the gastric, which is the peptic ulcer or gastric ulcer, or GI ulceration, from first increased HCl secretion, second decreased secretion or production of protective gastric mucus. Other manifestations in patients with Cushing syndrome would be the mineralocorticoid excess, which will lead to the hypertension and edema, and that's from the due to the fluid electrolyte, fluid retention and sodium retention and loss of the potassium, but mostly here because of the fluid retention and sodium retention. Adrenal androgen excess may lead to acne, may lead to virilization in women, which is the in which will be presented in like menstrual irregularities or menstrual disorders or hirsutism. The feminization in men, like the gynecomastia, impotence, the oligomenorrhea, which is the usually it's due to the decreased ovarian production of the estrogen and progesterone, secondary to the interruption of the normal hormone feedback mechanism as a result of the increased androgens. Patients also may exhibit or be presented with mood disturbances, emotional instability, or insomnia, or psychoses. This is some of the manifestations in patients with Cushing syndrome. Diagnostic studies will cover that in more details in adult health course, but we will recommend the 24-hour urine collection for the free cortisol. And these are the numbers in terms of values daily. as diagnostic for Cushing syndrome. So we are also when we do this urine 24-hour urine collection, we are also evaluating the adrenal androgen metabolites. There are certain metabolites that will result from the metabolism, of this adrenal hormone, and that will be presented on the urine, and that can be part of the evaluation and assessment, or as we diagnose patients with Cushing syndrome. Another diagnostic test will be the dexamethasone suppression test, in which this diagnostic test, it's another test that we will also cover in adult health too. Salivary cortisol levels and ACTH levels. We will cover all of these in adult health too. We can also subdiagnose patients with like the pituitary Cushing disease versus adrenal Cushing disease or Cushing syndrome based on the results of these diagnostic tests or studies. They are very helpful in terms of subdiagnosing patients with a specific type of Cushing, if that's due to the adrenal gland or pituitary gland or hypothalamus. So that will also be discussed in more details on depth, I would say, in adult health though. Now, the pharmacotherapy of the Cushing syndrome. So the anti-adrenal drugs. So because this is the hypercortisolism. This is a hyper secretion of the cortisol. So we need the medications to suppress the adrenal gland to produce less of that hormone, of the cortisol hormone. So anti-adrenal drugs used to treat severe Cushing syndrome occurs with prolonged glucocorticoid therapy. So this medication should inhibit the corticosteroid synthesis by the adrenal gland. So these drugs that are not curative, they usually limited to 3 months of therapy. And one type of these medications is the lysogen, which is the mitotane. Another medication will be ketoconazole, Nizoral. We'll explain later on, but we'll focus on this mitotane, which is a lysogen. And next is the opposite to the Cushing syndrome is the Addison's disease or adrenal insufficiency. There's another term used for Addison's disease, adrenal insufficiency. So the adrenocortical insufficiency, there's primary cause. The main thing here is that there is a decreased secretion of the cortisol. Also, we will find the aldosterone also secretion is going to be reduced. Hypoaldosteronism, and hypocortisolism. Like there is low cortisol level, there is low aldosterone level, and there is a decreased androgens. That's why the patient will have a we'll talk later on about the manifestations, the effects that would result from the effect of each and every one of these hormones. So the causes or etiologies for patients to develop the adrenocorticotropic insufficiency or Addison's disease, most commonly caused is the autoimmune response. in which there is a destruction of the adrenal glands, which is responsible for the production of these hormones, mainly the cortisol. So in other words, it's idiopathic, or another, we can say, autoimmune disease or response. TB, there's too many, like etiologies. The TB, tuberculosis, fungal infections, sepsis, septicemia, the drugs, medications like the medication we mentioned earlier for the Cushing syndrome, which is lysogen, mitotine. Some toxins could result in the adrenal gland insufficiency. Status post adrenalectomy, which is the surgical removal of the adrenal gland. That also may lead to the adrenal gland insufficiency or Addison's disease. Adrenalectomy. The metastases like metastatic cancer, trauma, the abdominal radiation therapy. All of these can be primary causes for the Addison's disease. Now, the secondary causes for Addison's disease, pituitary tumors, tumor that affects the pig gland, or postpartum pituitary necrosis, like what is called the Sheehan syndrome, for example, which is known as a syndrome that would result from the bleeding after during the postpartum period, and that which can be explained by that there is a decreased perfusion from due to this hemorrhage. There will be a decreased perfusion to the pituitary gland, and then that could result in Addison's disease. Another cause or etiology would be hypophysectomy, and that's when patients develop a pituitary gland adenoma, and in which that we will introduce the forceps or during craniotomy to remove the pig gland or the tumor affecting the pig gland. So that's called hypophysectomy, which is the pituitary gland tumor removal, surgically removed. There are two options, either through the nose or through the sphenoidal sinus, or through the craniotomy, open the cranium surgical procedure to remove the tumor. That's called hypophysectomy. And then the radiation, either to the pig gland or the brain. Secondary, other secondary causes for the which here is the most of the cases will develop this Addison's disease because of the sudden cessation of the long term. The sudden cessation of the long term, in which that patients develop a high patient will be on a high dose of steroid therapy. So the abrupt cessation of the steroid therapy will lead to the suppression of the steroid production through the negative feedback mechanism will be completely stopped, and that will lead to the atrophy of the adrenal cortex. So the steroid therapy must be withdrawn gradually, tapered off, to allow for the pituitary gland production of the ACTH hormone to activate the adrenal gland to produce the cortisol. However, the iatrogenic Addison's disease, and that may be maybe due to the adrenal hemorrhage, due to the use of sometimes anticoagulants, anti-neoplastic chemotherapy, medications like fungal meds like Nizoral, or bilateral adrenalectomy, the surgical removal of both adrenal glands, that may lead to the iatrogenic Addison's disease. Most often, this disease occurs in adults aged 30 to 60, affects both genders equally, and the most common in white females is the autoimmune Addison's disease. So tapering off medications, very important. Do not stop the steroid abruptly. Has to be tapered off. And we'll go over some questions in class, explaining about this concept of tapering off the steroids and the importance and significance of that concept. Addison's disease and clinical manifestations. Patients usually tend to develop the manifestations of Addison's disease when more than 90% of the adrenal cortex is destroyed. So it's patients will not be or the manifestations will not be prominent or visible or exhibited by the patient until a large extent or component of the tissue is being destroyed from the adrenal gland, especially the cortex. The patient may develop what is called progressive weakness, fatigue, weight loss, anorexia. These are like primary features of the Addison's disease. The patient will have what is called skin pigmentation, hyperpigmentation, and here you can see that there isn't like in areas in which that the hyperpigmentation of the skin that is exposed to sun, like areas exposed to sun, pressure joints, over joints, and the creases. And the rationale for that would be that, in primary insufficiency, the plasma ACTH hormone and the melatonin stimulating hormone, the MSH levels, ACTH and MSH levels, they are elevated because of the feedback mechanism, or which is the hypothalamus, pituitary gland, target organ feedback mechanism. So again, it's because of the ACTH, MSH hormones that will lead to the increased pigmentation. Now, vitiligo, which is the patchy areas of the pigment loss with increased pigmentation at the edges, and it's seen in patients with primary dysfunction of the adrenal glands and caused by autoimmune destruction of melanocytes in the skin. However, in the primary autoimmune disease, the destruction of the melanocytes lead to the patchy areas of decreased pigmentation. Now, the clinical manifestation of Addison's disease, it's like in dichotomy, so it's the opposite to the Cushing syndrome. Hypotension instead of hypertension in Cushing syndrome. So here the patient will have a low blood pressure, postural, especially postural hypotension, and this is due to the hypovolemia. And hyponatremia, that's due to the low aldosterone secretion. Because remember that the aldosterone hormone responsible for the sodium water retention and potassium excretion. So with the low aldosterone, then there will be hyponatremia, hypovolemia, and the hyperkalemia. So that's another explanation for the hyperkalemia, which is the low aldosterone secretion, hypercalcemia, and nausea and vomiting. And this nausea and vomiting, that's due to the low cortisol, which will lead to decreased GFR and gastric acid, in which that in turn will lead to or cause the decreased bone excretion. And then that's the, that explains why patients would have nausea and vomiting and weight loss. So again, decreased GFR, decreased cortisol lead to decreased GFR and gastric acid leads to decreased bone excretion, and that will lead to the nausea and weight loss, vomiting and weight loss. Now diarrhea, diarrhea, and then the low adrenal androgen levels. So the decreased body axillary and pubic hair, especially in women, because the adrenals produce most of the androgens in females. The secondary adrenocortical hypofunction in Addison's disease, that's from the lack of the ACTH secretion, And the manifestations is common with Edison's and no change in the skin pigmentation. Complications. These are some of the complications that may affect or be presented in patients with Edison's disease. And again, said in the risk for life-threatening crises caused by insufficient adrenocortical hormones or sudden sharp decrease in these hormones. So the first one here is the triggered by stress following the sudden withdrawal of steroid replacement therapy. Hyperkalemia. Again, that's due to the decreased aldosterone secretion. Hypoglycemia from the decreased gluconeogenesis reduced, which is the process of making glucose from protein. Remember, we said that the protein is stored in the liver, and then at times of hypoglycemia, then the liver will convert protein to glucose, which is the gluconeogenesis. So there is, so this process is being decreased. So from the decreased gluconeogenesis, along with the depletion of liver and muscle glycogen, that leads to hypoglycemia. Diagnostic studies for the Edison's disease, the subnormal levels of cortisol in the blood, the stimulation test, ACTH stimulation test, that's the most definitive diagnostic test. And, as you said, that we are going to cover most of the diagnostic tests or studies and the explanation of each and every study from this list in Adult Health Show. So the Edisonian crisis, it's a life-threatening condition. Edisonian crisis, severe Edison's manifestations or Edison's disease manifestations of this condition it's a life-threatening condition. It's called Edisonian crisis, which is the acute exacerbation of the adrenal insufficiency. Stressful events or triggering events like surgery, trauma, infection, that could lead to the exacerbation of the symptoms. So unless intervention is initiated promptly, sodium levels will fall, potassium levels will rise rapidly, and that could lead to the blood volume to depletion and severe hypotension. So treatment for the Edisonian crisis as a life-threatening treatment should be directed at shock management and high dose of hydrocortisone replacement therapy, and large levels of sodium and dextrose, like D5, should be administered to reverse the hypotension and the electrolyte imbalances. Now, Edison's disease, pharmacotherapy with ACTH hormone. So we'll focus here. I mean, the most of the remaining content on for like Edison's disease, it's basically its own steroid therapy as a replacement. So replacement therapy with a steroid, synthetic steroid. So as we read from this slide, that the steroids the ACTH and related agents rarely used as medications, must be given parenterally and have many side effects. So we are going to review some of these side effects of the long-term steroid and the upcoming or the following slides. Like, for example, this table explains or provides the specific adverse effects of long-term steroid therapy and like behavioral changes, diet changes, the immune response, metabolic changes, especially with the hyperglycemia, the electrolyte imbalances like hypernatremia and hypokalemia, fluid retention, weight gain, hypertension, edema, myopathy, affecting the muscles, muscle wasting, and muscle weakness, osteoporosis, and the peptic ulcer disease. Pheochromocytoma. So pheochromocytoma, it's a rare condition, and it's a disease that affects the adrenal gland, in which most of the time that we have patients having a tumor affecting the adrenal medulla, in which there will be excessive production of catecholamines, which is epi and norepinephrine. So, and we know that the epi and norepinephrine, they are vasoconstrictive, they will increase the blood pressure, and they also type of hormones or chemicals that will they are very vasoconstrictive and increase the blood pressure. And the 10% of the pheochromocytoma cases are malignant. The 90% known to be to be benign. So if undiagnosed, patient may develop diabetes mellitus, cardiomyopathy, and could lead also to the death because of the extremely high blood pressure and intensive effect of the epi and norepinephrine, the catecholamines. So the most recent, some of the research findings is just kind of like FYI, is that they found that the deficiencies of iron or copper and in diets high in like manganese, they have been associated with pheochromocytoma. Deficiencies of iron or copper and diets high in manganese, they are have been associated with the pheochromocytoma. Although the cause of that tumor is not yet known, it's now well understood. The catecholamines, they stimulate the alpha and beta receptors at the sympathetic nervous system, in which that will lead to severe hypertension, severe elevation blood pressure. So the intermittent episodes of the hypertension or attacks, they vary in length from few minutes to several hours. So this elevated blood pressure could last for a few minutes. Others may last for several hours. So it's kind of dangerous because that may lead to or cause a CVA or stroke. And so that's why it's life-threatening and could lead to death. The long-standing effect of that, we said it could lead to the cardiomyopathy because of the sustained increased blood pressure with high levels. So again, we said the etiology is unknown, but that most, 10% of the cases can be, the tumor. If that's the tumor, it's a tumor usually. But if that's, that 10% is about like malignant, and then the 90% of the cases are benign tumors. So these are some of the precipitating factors that may erupt or potentiate the episode of increased epi and norepi and potentiate the condition. Anesthesia, narcotics, or antagonists, and the like TCAs, tricyclic antidepressants, dopamine, having childbirth, some radiographic contrast media, some dyes and food that is high in tyramine, like wine or aged cheese. Now, an important concept here in Patho Pharm, and also we're going to revisit this in adult till 3, in which that patients with this condition, with the pheochromocytoma, one of the nursing assessment techniques should not be done, should not be patients with this condition should not be palpating the abdomen. So because the increase in the intra-abdominal pressure, like palpation, it's not recommended for patients with pheochromocytoma, because this can cause a hypertensive episode, because once you palpate, you may stimulate the adrenal gland, the tumor or adenoma, to secrete more or excessive amount of the epi and norepinephrine, and that can lead to the hypertensive episode of this. So what are the manifestations of this disease with the significant secretion or elevation of or production of this epi and norepi as catecholamines? The triad's manifestation of symptoms are STP, severe bounding headache, tachycardia with palpitations, profuse sweating, and all of these are expected manifestations and outcomes from the epi and norepi production, especially with large amounts in the blood. So the interment signs and symptoms. So as we said, other than just the triad, so we have as we said, headache, tachycardia, profuse sweating. So other than these, patient may develop also a pain in the chest or abdomen, which will be accompanied, associated with with the nausea and vomiting, heat intolerance, tremors, apprehension. These are interment signs and symptoms, other than the 3 triad symptoms mentioned earlier. So the diagnosis is just to highlight, just significant 2 main things about the diagnosis, and we will discuss it in depth and adult health too. So the first one is 24-hour urine collection, and the second one is the vanil mandelic acid, VMA testing, and the VMA testing, we anticipate that it's part of this 24-hour urine collection, is that as we measure the catecholamines, the metanephrines, which is the metabolites of the breakdown product of the catecholamines, which is the result of the metabolism of the catecholamines. One of them is a VMA. So the VMA, so we measure so when we collect the 24 urine out, urine for 24 hours, we will send to the lab, and we will test it for the catecholamine content, for the metanephrines, for the VMA. And normally the VMA is supposed to be 2 to 7 milligrams daily, 24 hours. The high levels are of the VMA. Suppose we have specific criteria for that, to have an accurate VMA level or testing with accurate levels, valid, reliable levels. We have to with a lot of patient teaching, some dietary recommendations, and we'll go in depth with this in adult health too. But the high levels at rest may indicate pheochromocytoma. So it has to be at rest, not during during the activity. So again, most of this of this in depth will be covered, and the content pertains to the diagnosis or diagnostic studies will be discussed in Patho and adult health too. The hypertensive crisis, that's the most common complication of pheochromocytoma, and the treatment of the hypertension, very important, so we can reduce the blood pressure, we can control it, but reduction of stressors is the most important for this condition. Reducing the stressors, or to avoid these stressors that may increase or may activate the episode of the pheochromocytoma. So the treatment of hypertension and or the pheochromocytoma episode, is to treat, trying to reduce and avoid these stressors. Even though that we will treat it with, with controlling the blood pressure, but the actual reduction is going to be, or control, in other words, the control of the frequency of these episodes is to reduce the stressors. Now, they recommend that patients should have a diet rich in calories and vitamins and minerals. So this should conclude the lecture for the adrenal gland disorders.